All right, welcome to another week of ICU Doc Talk. Today we're going to talk about one of my favorite things to talk about, which is hypoxemia, which is when a patient or a person doesn't have enough oxygen circulating in their system and they're not doing well, and maybe they're circling the drain and they're dying. How to address it, the causes of hypoxemia, and how to get them out of it. That's what we're going to talk about. I'm going to talk about it in many different settings and many different disease states. So let's do it. So there's many different reasons why someone can be hypoxemic. It's not just they stop breathing. There are several components that all come together to make sure that someone's bloodstream has enough oxygen so that oxygen can be delivered to your tissues. Why do you need oxygen? I guess let's back it up. Why do you need oxygen? It's because your mitochondria need oxygen. The little powerhouse of your cells, they need oxygen as the electron acceptor to metabolize and to create ATP, which is like the fuel currency of your cells to create ATP. So that's why you need oxygen. So all of your physiology and your brain and your how all of that works is all to detect how much oxygen you have, how much carbon dioxide you have, and that drives you to want the physiological response to actually breathe, to take a breath. So, and there's just so many reasons a person could be hypoxemic. So many reasons. So let's just go through this a little bit. So if you walk into a patient's room who's, they're not doing well, you hear they're hypoxic. And just to back it up, there is the difference between hypoxic and hypoxemia. And we often use them interchangeably, which they're not. And I do by accident all the time. I think I've already probably done it in the 2 minutes of talking. So hypoxemic means low oxygen content in the blood. Emia means blood. Hypoxic, so that means low oxygen in the blood. Hypoxia means that there's low oxygen supply in the actual tissues of the body. So you can look at someone and they look hypoxic. And you might be hypoxic, but you may not be hypoxemic. So I guess I think I started out talking about saying this episode is about hypoxemia, but I guess it's about hypoxia. It's about both. We're talking about both here. So hypoxemia, again, is low oxygen content in your blood, and hypoxia is low oxygen that's actually delivered, that's in your blood tissues itself, okay? Just to make that distinction. So you walk into a room and a patient appears hypoxic. What does that look like? What does hypoxia look like? Well, people look blue. That's not just a Hollywood exaggeration. So like blue lips, that is real. You can have deep blue lips and you look and your skin looks like ruddy. It's just not getting good blood. You can see it in someone's skin if they're not getting good oxygen supplied to their tissues. And then maybe they're short of breath, and then there's another term that we use a lot, which is work of breathing. How much work is someone putting to actually to draw in oxygen? Me and you right now, hopefully you are as well. We're breathing comfortably, right? We're not thinking about our breathing. But as soon as something is wrong in your body, you become aware pretty quick that you're not breathing well, and you start working at breathing. And the worse it gets, it becomes the sole purpose of what you are doing. You cannot concentrate on anything else, and you start recruiting new muscles to breathe. Right? Right now, I'm just using my diaphragm, just going up and down. It's just drawing air in and out. But as you start working harder to breathe, you start recruiting these other muscles, like your abdominal muscles and your obliques, your muscles that kind of flank your ribs. You start using your intercostal muscles, which are in between your ribs. You start using your sternocleidomastoid muscles, which are the muscles that kind of go from the back of your skull to your clavicle. That helps to lift your rib cage up a little bit. So someone can really start straining. So that's work of breathing. So if I walk into a patient's room, even if they're not hypoxic, so you can have high work of breathing and not be hypoxic. That means your work of breathing is catching up with your oxygen demands and you're not hypoxic. So you can have an oxygen saturation. And again, what do I mean when I say oxygen saturation? That means the saturation of your hemoglobin. Your hemoglobin, one of the points of your hemoglobin is to carry oxygen, right? The iron in your hemoglobin, it carries 4 molecules of oxygen. Each one of them does. And it carries that, picks it up in the lungs. It's like a shuttle, and it shuttles it off to your tissues. It gets to capillaries, and then it drops that off on your tissues, and it comes back around to the lungs to do it all over again, like a merry-go-round. So if your oxygen saturation, that's what when you put a probe on your finger, which is a pulse oximeter, what is that measuring? Well, it's using a couple different wavelengths of infrared light, and it's actually looking at your hemoglobin, how well it's saturated with oxygen. That's why we call it oxygen saturation. And it can look at how much oxygen is on, the hemoglobin, and that can tell you. So what my point is, someone can have normal oxygen saturation, and they're at 100%, but they can still have a high work of breathing. And now they might have a high work of breathing because they're hypercarbic, meaning they have too much carbon dioxide. And that's kind of a topic for another time. I will be talking about that a little bit, but I'm mostly talking about hypoxia. Anyway, when I'm looking at a patient, I assess their work of breathing. Are they really working hard? I auscultate the lungs. I listen for the lungs. I listen for clear and bilateral breath sounds. I listen to see if they have any wheeziness. I listen for unilateral breath sounds. So that's kind of just a really quick and dirty basic assessment I'm making of a patient who is hypoxic. Now let's back it up with a couple equations. I'm not going to spend too much time on this, and I know it's hard to hear about equations if you're not seeing them. And also some people just don't have mathematical inclination, so it's fine. I won't spend too much time on this, I promise. But there's kind of four concepts that influence how your oxygen is delivered and how it is in your body. One of them is oxygen content. Okay, so oxygen content, and I won't even spell out the equation here, but the oxygen content itself is dictated by hemoglobin. So content is how much oxygen your blood is carrying, and that depends on your hemoglobin concentration. So the more hemoglobin you have, the more oxygen you're able to carry. And then how much is that hemoglobin getting saturated with oxygen, like I talked about. So if your hemoglobin's only carrying one oxygen, then you don't have good saturation of your hemoglobin, and your content is not very high. So it's mostly your oxygen, it's mostly your hemoglobin that's dictating how much oxygen is, how much oxygen your blood contains. Now, oxygen itself can also dissolve into your blood plasma. Kind of like how you like open up a can of soda, and a bunch of gas comes out. That's carbon dioxide. That's dissolved directly into it. The same thing with oxygen. It can dissolve directly in your bloodstream, but it's a very, very small portion. That accounts for the content of your blood, and that's we measure that directly. The PaO2, the oxygen tension, that's actually in your blood. Anyway, the take home there is oxygen content is mostly dictated by how well your hemoglobin is saturated with oxygen, meaning every hemoglobin carries 4 molecules of diatomic oxygen, O2, right? Okay. So the next concept is oxygen gradient. What gradient are we talking about? I'm talking about the gradient between your alveoli and the oxygen content and the oxygen in your bloodstream, or the oxygen that's dissolved in your blood plasma. So it's the oxygen gradient is simply the difference of the oxygen that's in your alveoli. The alveoli is just the tiny sacs that are in your lungs, the breathing part of your lungs where you breathe in and you draw air in. And so it's that minus how much oxygen is dissolved in your blood plasma, like I said. So the alveolar oxygen is dictated by what? Well, it's dictated by the FiO2, which is the fraction of inspired oxygen. How much fraction of inspired oxygen? What is the percent of the oxygen that you're breathing in right now? Right? So it's for me and you, hopefully for you as well, it's 21%. That means you're not very sick if you're able to do that. But we can ratchet that up to 100%. So we can increase that. And then that's minus the atmospheric, that's times the atmospheric pressure minus the water vapor that's around, because that will subtract from the water. The atmospheric pressure, the partial pressure of water that's in the air will subtract from how much oxygen you're receiving as well, if that makes any sense. And then, how much oxygen you have in your alveoli is also dictated by how much carbon dioxide is there. The more carbon dioxide, so if you remember, this is basically, I'm talking about Dalton's law. Again, don't get too lost in the weeds. I swear I'm going to move quickly from this if you're like, what is he talking about? I will get through this very quickly. Dalton's law is that the total of pressure that you have, like the sum of all the gases that you have, the total pressure is a sum of all the gases that are present. So my point is, the more carbon dioxide you have, the less that will supplant the amount of oxygen that you have, and that affects how much alveolar oxygen that you have. Okay, anyway, we're going to move on from there. So that's alveolar oxygen, the gradient between these two. And then there's something called the P to F ratio, which is a more useful clinical measurement, which is the PaO2 ratio with the FiO2, how much you're delivering. So the PaO2, if your PaO2 is like 100 and your FiO2 is 21%, that means that's pretty good. You're getting a good PaO2. You're getting a lot of bang for your buck. But if your And that's a, that would be a P to F of what? Like 500. That's really good. But let's say you have a PaO2 of 100 and you have an FiO2 of 100%. So you're only achieving a PaO2 of 100 despite an FiO2 of 100%. Well, that's a P to F of 100, which is low. So a P to F ratio is a nice, quick, and dirty clinical tool to use to see how what's going on. It gives you a clue of what's going on in the lungs. If it requires 100% FiO2 to achieve a measly PaO2 of 100, something's wrong. Okay, so I swear I'm done with the equation stuff, but I might harken back to those things a little bit here. So let's talk about the causes of hypoxia. Okay, so traditionally there's like 5 main causes of hypoxia. All right. And some of them, a lot of the categories fit into a lot of the reasons that cause hypoxia fit in like 2 of these categories, and the rest are just a little bit lower. So I'm going to start with the categories that don't have as many causes for hypoxia and go to the what are the main causes of hypoxia, if that makes any sense. Anyway, so the 5 main causes of hypoxia are hypoventilation, low FiO2, that stands for fraction of inspired oxygen. The percentage, it just basically means the percentage of oxygen that you're bringing in. Shunt, a right to left shunt. Another one of them, number 4, is a VQ mismatch, the ventilation to perfusion ratio. And number 5 is diffusion. So I would say the one that's the least likely that when you're walking in is decreased FiO2. So it's kind of a weird category, I've always thought. So I didn't come up with these categories. It's kind of the standard categories of like what causes hypoxia. Low FiO2, like, okay, I guess if you're hiking on Mount Everest, you have low FiO2. And that's a reason why you're hypoxic. Another one that fits in this category is hypercarbia. Hypercarbia can cause low FiO2 because, as I said, according to Dalton's law, the more carbon dioxide you have hanging out in your alveoli, that will decrease the partial pressure of your oxygen as well. So that's that category, low FiO2. The other category that doesn't have as much bang for your buck is low diffusion capacity. This is usually like something like interstitial lung disease, which is a chronic disease of the lungs. That you have terrible gas exchange. The interstitium between the alveoli and the capillaries surrounding the alveoli that are trying to pick up the oxygen, it doesn't allow good diffusion of gas exchange. So your carbon dioxide and it's usually the oxygen does not pass through very, very easily. And that's usually a chronic condition. So it's usually not an acute condition. Someone's usually not hypoxic because they have an acute drop in their diffusion capacity, if that makes sense. So which isn't to say that someone who has interstitial lung disease doesn't become acutely hypoxic. They're just getting something on top of what's going on. Or they're just developing end-stage lung disease with their diffusion capacity. Anyway, let's move on. All right, let's move on to hypoventilation. So what is hypoventilation? Ventilation means how much you're eliminating carbon dioxide from your bloodstream. So hypoventilation is a disorder of having too much carbon dioxide in your bloodstream or in your alveoli or both, and that causes you to be hypoxic. So hypoventilation can be, or hypercarbia. That's what that means. Hypercarbia means too much carbon dioxide. It can be caused by many different things. Now, to be fair, hypoventilation usually, the more of the concern is causing hypercarbia, which is hypercarbia and hypoxia are different things. They're not the same thing. But hypercarbia can cause hypoxemia, but hypercarbia also has issues of its own where you're not eliminating enough carbon dioxide. Your blood becomes acidotic because of that reason. It also causes you can get hypercarbonic narcosis, which makes it so it decreases your drive to breathe even more. So what are the reasons that you can get hypercarbia from hypoventilation? Things that can cause hypoventilation are central nervous system depression, like for one thing, trauma to the head can make it so can decrease your drive to breathe if you have trauma to like your brainstem. That's a big problem if you're in that situation. Narcotics, particularly opiates and benzodiazepines, particularly when those are used together, they stop that drive of in your cerebral spinal fluid to want you to breathe. It's the reason people die from like opiates is because they stop breathing. It makes your body not care about breathing, and you just stop breathing and you don't care about it because that drive is gone. Many neuromuscular disorders can cause hypoventilation. There's a whole list of like Guillain-Barré or like polio or ALS, Lou Gehrig's disease. Problems with your phrenic nerve, which controls your diaphragm, if you have a neuropathy with that. Other myopathies, myasthenia gravis, muscular dystrophy, polymyositis. And then anything that can damage the diaphragm, and as I said, the phrenic nerve can cause hypoventilation. Having obesity, hypoventilation syndrome is a reason you can be, which is also called Pickwickian syndrome, that can cause someone to hypoventilate. Another thing that can cause hypoventilation is like poor chest wall compliance. If you have a flail chest from trauma, or if you have really bad, what we call kyphosis, which is like kind of a hunchback physiology, kind of limiting the way you ventilate. So anyway, so that's hypoventilation, and again, it causes hypercarbia. Hypercarbia can cause hypoxia. Remember, we're talking about hypoxia mostly here. Hypercarbia, I could do a whole nother lecture about hypercarbia and the problems with hypercarbia. Okay, the next category we're talking about is the big categories, right? It's two categories: a shunt, whether it's intrapulmonary shunt or a cardiac shunt, and then VQ mismatching. And a lot of these things really confuse a lot of people. Here's something I really want to boil things down very basic. Let's just let's just zoom out here, or zoom in, whatever. So if you have a piece of paper, you don't need to do it, but let's imagine you have a single alveoli, okay? It's like a little balloon, and you have a single capillary that's passing by. All right. Now let's imagine that alveoli represents the entire lung. That's it. That's all you have for gas exchange, to bring in air. And let's imagine something is in that alveoli, completely blocking it. But the blood is still flowing, okay? So alveoli is V, is how much you're ventilating. And the blood flowing is blood flow, which is Q. And that's where the V to Q equation comes into play. So if you have something that's completely blocking your alveoli, all of your ventilation, that means your V, your on top, your numerator is 0. And your blood flow is, really, really high. So that means your V to Q mismatch is approaching 0. Just think how many disease processes fit into this category, what I'm describing, where stuff is in your lungs. Stuff is in your alveoli. There's so many things. We could just go through it, like pneumonia, having something in your alveoli. That's an infection in your alveoli. Aspiration, having fluid, gastric contents, blood in your alveoli. Pneumonitis, having inflammation in your alveoli, so they just don't really work. So that, you can't aerate them. Having what was I going to say? Atelectasis. That's collapse of your alveoli, which is not to be confused with the collapsed lungs. Just if people are confused. Atelectasis means your alveoli, the tiny little air sacs, are just collapsing in different regions. Alveoli are everywhere, right? You have tons and tons and tons of these tiny little air sacs all over your lungs. But that brings us to a collapsed lung. What is a collapsed lung? That's called a pneumothorax. Well, a collapsed lung would also collapse your alveoli, which can cause this VQ mismatch that approaches 0. There's just so many there's so many issues you can have, things getting in your alveoli that then cause hypoxia. Now let's take it on the other end. Let's take that little alveoli and the one little capillary that's passing outside of it, and let's stick something in so let's say the alveoli are nice and free, but now you have something in your capillary. And let's say that capillary represents all of your flow. And what are the things that can be in that, like a capillary bed or in your pulmonary vasculature? Well, a pulmonary embolism, which could be a blood clot. You can also have an embolism that's like air, like carbon dioxide from a medical procedure where someone accidentally, you get a laparoscopic surgery, and you actually get carbon dioxide that's infused into your bloodstream. That would be bad, and that causes an embolism to your lungs. You can get fat embolism, like if you break your femur, some of the bone marrow fat can break off, go to your lungs. That's an embolism. You can get a cement embolism from like an orthopedic procedure where they're hammering a bunch of cement into your exposed bone. That can go up. My point is, an embolism doesn't just mean blood clot. It usually is a blood clot, but it doesn't mean that. Anyway, what's my point? So that you have an embolism, a clot of some sort that's gone to your lungs, to your pulmonary vasculature. It hasn't gone to your airway, right? It's in your blood vessels, not your airway. But your airway is nice and clear. So you're breathing and you're ventilating, but you're not perfusing your lungs. So your ventilation is, good, but your perfusion is approaching 0. So your V to Q approaches infinity. So that's a VQ mismatch where that causes dead space ventilation. That's what dead space ventilation is. It's where you have something in your capillary bed, or something, not just your capillary bed, or your lungs. You can have a saddle embolism, right? You can have major pulmonary embolism. And that's causing dead space ventilation. Dead space ventilation, the way to think of it is you're diluting out. So you're stopping gas exchange, and your end-tidal CO2 is going down. Why does your end-tidal CO2 go down? That's how much carbon dioxide you're breathing back out with dead space ventilation. It goes down because you're diluting how much carbon dioxide you're breathing out, and you're concentrating the carbon dioxide within your bloodstream. And that is so you're increasing your dead space ventilation. Remember, you have normal anatomic and alveolar dead space ventilation, where a lot of your conducting airways don't perform any gas exchange. So you have dead space ventilation with that. You can also have dead space ventilation if say you have someone who's intubated with a breathing tube and you have them on high airway pressures, like a high PEEP, and you're expanding your alveoli so much that your capillaries the perfusion can go down. So you can actually increase your dead space ventilation. There are ways to measure dead space ventilation rather than I swear I'm not. It's hard to talk about this without talking about equations. But there's a way to calculate dead space ventilation by measuring your end-tidal CO2 and your partial pressure of your carbon dioxide. There's also something called volumetric dead space ventilation, which actually measures your alveolar dead space in real time. Anyway, I digress from that point. Okay, so that's kind of like VQ mismatch, and all these things fit in this category of intrapulmonary shunt VQ mismatch: ARDS, atelectasis, pneumonia, pneumonitis, all these things that can cause hypoxemia. And then, right to left shunt, that means the right side of your heart, which is deoxygenated, that blood is somehow getting to the left side without getting oxygenated. So that can happen through your heart, like a PFO, a patent foramen ovale, where you just have crossover, which is a congenital hole that's in the middle of your heart. A VSD can also cause this, a ventricular septal defect as well. I mean, basically, the way to think of a right to left shunt is that the alveoli are being bypassed. So that's intracardiac shunts, and hepatopulmonary disease can also be a sign of, can also be a cause of right to left shunts. Anyway, so that's kind of some of the background, the causes of all the things that cause hypoxemia. So let's talk about management, clinical management. So let's go back to our scenario, or maybe I can come up with a story. I have so many stories, right? I deal with hypoxic patients every day. Every day I'm at work. I'm dealing with this every single day. So let's work into the management, from doing the less to doing the absolute most of what you can do to manage with someone who's hypoxic. So, okay, you come into the patient's room. You examine them. This is what you do, right? Look, and examining is looking at them. Look at them. Just stand there and be like, just look. Just behold them. What is going on? Like I mentioned before, what is their work of breathing? What are their vitals? Do they appear cyanotic, meaning do they look blue? Are they circling the drain? Do you need to intervene now? And then look at what is the oxygen delivery. What is going on with their oxygen? Are they on room air, which is what I'm breathing right now? I'm breathing just the room air that's here. Are they on nasal cannula, which is a little cannula tube that goes into your nose that delivers a certain amount of oxygen, not a lot of oxygen, right? And that that we can increase that flow, but it's very limited. Like you can 2 liters up to 6 or 8 liters. After that, the flow gets so much, there's probably not that much getting in. It's probably just flowing around the nose. And there's only so much. So remember this concept of fraction of inspired oxygen, FiO2. So right now you're breathing with 21% oxygen. So through a nasal cannula, what's the fraction of inspired oxygen through a nasal cannula? Well, it depends on how much flow you're giving. So flow is measured in liters per minute, how much actually air you're flowing through. And you create flow by, having negative pressure. So when you put on a nasal cannula, which is like the smallest thing you can do, the lowest measure you can do to give someone oxygen, if you have them on like 1 liter, that's like 24% FiO2. If you have them on 2 liter, it's like 28%. 4 liter, it's about 35%. And then you get up to 6 liter, you're getting up to, you're really bumping it, you're really maxing only like 40%, 45% FiO2. So if someone needs more flow and they need more FiO2, you're going to find out real quick if you put that nasal cannula on and they're still just really, huffing and puffing. And then from there you can go to a face mask, which is a mask that covers both the mouth and the nose. You can get more flow out of that. You can get maybe a little bit more FiO2. You can put someone on a face mask of like 10, get an FiO2 of around 55%. But again, you cannot go to 100% FiO2 on a face mask. Now you can escalate from there to a non-rebreather. Now, the main thing about a non-rebreather is basically like a face mask with this like bag thing looking on it that has a one-way valve. so that when you exhale, you're breathing the carbon dioxide out, and it can't get back into the face mask. So whereas a simple face mask, there is some rebreathing of carbon dioxide going on. If you keep your flows high enough, you can a lot of times you can pump out that rebreathed air. But a non-rebreather will really help to get that rebreathed air. That's why it's called a non-rebreather. Non-rebreather, your flows can get up to 15 liters a minute, and your FiO2 can get higher, even higher there. You can approach 80 to 90%. So if I walk into a patient's room and they're really huffing and puffing around room air, I'm not going to put them on nasal cannula. I'm going to be like, let's put a non-rebreather on this patient right away, or we can escalate even further than that. So here now you can really escalate to like an actual face mask that has a bag on it where you can pump air into you can assist the patient with hand ventilate assist with like something like an ambu bag or a Jackson-Reese circuit. You can Google those things to take a look, but they're basically a face mask that you can apply and hold, and you can do very high flows and really good FiO2, and then there's a handbag that you can help assist their oxygenation, their ventilation. And then if they're not breathing, you can breathe for someone with this. So the other methods I was talking about, you can't breathe for someone, but with this, you can finally breathe for them. So if I come into the patient's room and if they're like circling the drain, maybe non-rebreather is not enough, I'm going to put on a Jackson-Reese or an ambu bag, which there are big differences between these things. And then just start bagging for them. When I say bagging, I mean the bag on the circuit, I'm moving it and pumping air for them. Usually, respiratory therapists are also there to help a lot with this management. Not just them, respiratory therapists aren't technicians, right? They're not just bringing equipment and using equipment. They're using their expertise as well to be like, what should we do? Here's this and that. Why don't we do this? I'm always consulting with respiratory therapists about their opinion about what we should do as well. Now, we should back it up a little bit and talk about high flow nasal cannula, which is a nasal cannula, but we're able to get much higher flows and much higher FiO2. We can get 100% FiO2 on high flows in nasal cannula. So if someone's having a purely oxygenation problem and not a ventilation problem, meaning they're not having problems ventilating their carbon dioxide, putting them on high flow nasal cannula is a great way to get their oxygenation up. It's very effective. Okay, so there's high flow nasal cannula that is also a very, very useful, powerful tool if someone is hypoxic. So you may be assessing a patient, and again, there's many reasons they are hypoxic that we've kind of gone over, and it's your job to you may not know exactly what's going on, but listening to their lungs and taking a look at them and then knowing a little bit about their history might really help you. Like if you walk into the patient's room and they're huffing and puffing, you listen and they have a bunch of wheeze, and you know that they have COPD, you're like, this is probably a COPD exacerbation. We should probably put them on BiPAP, which is the next thing that need to talk about, right? Now we're talking about positive pressure ventilation. Now I already have talked about positive pressure ventilation a little bit, right? Putting on an ambu bag or a Jackson-Reese, and you're pushing oxygen in. That's positive pressure. High flow nasal cannula does provide a little bit of positive pressure, but it's mostly you're still relying on the patient breathing on their own, which is negative pressure, right? When your diaphragm goes down, you're creating negative pressure, and that's how you're drawing air in. But now you got to ask yourself when you're looking at a patient, how bad do they need positive pressure? Patients that often need positive pressure ventilation are those with COPD, those with heart failure that are having an exacerbation, that they have fluid overload, and they need positive pressure to stent open their airways from all the edema that's happening in their lungs. Other people that need positive pressure ventilation are like if someone is pregnant, they have they can have that atelectasis that we're talking about, high obesity. Meaning, so when someone's obese, and the more obese that you are, you have more pressure on your chest. The compliance of your chest wall. Remember, compliance means think of like a balloon. If you can blow up a balloon really easily, that's very highly compliant. If you try to go blow up a propane tank with your lips, you're blowing into a propane tank, you're not going to do anything, right? That's very low compliant. So compliance goes down as obesity goes up because of the chest wall. There's more fat tissue around the chest wall, and it's harder to move the rib cage and the chest wall to create meaningful ventilation. So obesity, people that are obese often need more positive pressure ventilation. Putting someone on that like BiPAP is a very good idea. Some people that are atelectatic, that have atelectasis, sometimes they need recruitment, meaning recruitment of their alveoli. Put them on BiPAP, put them on positive pressure ventilation. And that will help stent open their little air sacs, their alveoli. Given that, you'll have better aeration and bring them out of that hypoxia. So you need to make that determination. If you're a clinician or whatever, listen to me. That's your job. You walk into the room and you got to be like, what do we do? Now you can start, depending on how, if they're like an extremist and they're doing really bad, sometimes you need to jump right to like BiPAP, depending on what their medical status is. But sometimes you can start with nasal cannula, and maybe the nurse already. If it's like a code, not a code. If it's like a rapid response, or you're called there because something's wrong, the nurse, and the primary team has already probably tried putting on nasal cannula. So you're not gonna be like, oh, let's put on nasal cannula. You're gonna escalate from there. Now you can put them on something and like a face mask, see how they do, and if they're still having trouble, okay, you need to go up from there. You need to escalate. Another thing that I haven't really mentioned in this discussion is someone can have stridor. Stridor is like when you have upper airway obstruction. Something is impinging on the airway. And stridor has a very unique sound. This is going to sound weird, but I'm going to try to imitate it, right? It sounds like this. Okay, that's stridor. Sorry, that was weird in your ear. But and the reason someone is struggling breathing is not necessarily because they're hypoxic. Like maybe they only need 21% oxygen, but they're not getting the air in. They're having problems generating good flow down into the lungs. And sometimes the solution for that is often, so there's a difference between turbulent flow and laminar flow. So when someone is stridorous, it's turbulent flow. The flow around their airway is highly turbulent, and they have to work harder to get that flow, and it's tiring them out. So to make the flow more laminar, you can lower the density of the air. How do we do that? We mix helium with it. If you're not familiar, maybe you think I'm joking, but I'm not. You mix helium with the oxygen, and that lowers the density, and it decreases the work of breathing. And that's called heliox therapy. It's very expensive. Not that affects me getting it. If someone needs it, I start it. A limitation to that is if they are hypoxic and they need 100% FiO2, that you can't give them heliox therapy because you can't get 100% FiO2 on heliox, right? Because it's a mixture of helium and oxygen. So you, of course, cannot have 100% of a mixture of those two things. Okay, so anyway, what's the main point I'm getting to is, okay, if all these things fail, well, you got to intubate them, right? Got to put in a breathing tube. So it is a case-by-case basis to decide if you need to put in a breathing tube. Sometimes someone needs a breathing tube, not even at all because they're hypoxic or they're hypercarbonic or their ventilation's fine. Maybe they're just, they're so delirious or what we call encephalopathic, they can't protect their own airway anymore. What if they have a really bad chronic liver disease and they're fulminant liver failure and they're so encephalopathic because their ammonia's through the roof that they're just sitting there with their mouth wide open and they can barely swallow secretions? Well, they're going to aspirate stuff into their lungs. Or what if someone just had a seizure? So bad that afterwards, we call it post-ictal, they're in a post-ictal phase where they're just so sedate from their seizure that they may aspirate and they're not protecting their airway. So that's another reason to intubate a patient is to protect their airway. So my whole point is there's many reasons why we intubate a patient and why we keep a breathing tube in. It's a case-by-case basis. It's not this simple thing that you just, if you're a non-medical person and you're like, oh, does that person need and you just look up in a textbook. No, it's something that comes with experience of knowing how to deal with patients like this. So anyway, so if they're hypoxic, you do all these therapies and then you determine where they need to go. Are they safe where they're at? Do they need to go to the ICU? How long are you going to keep them intubated? Okay. And now let's say they're intubated. You brought them to the ICU. You now have them on 100% FiO2. You have them on a nice PEEP setting, which is a different pressure setting. Don't worry about it if you don't know what that is. And guess what? They're still hypoxic. Maybe their oxygen saturation is like 70%, and they're just hanging out there, and you can't get them up. What do you do? Well, there's adjunct therapies, right? So you can do a couple other things to get them out of that. Sometimes if they're on a ventilator, taking them off the ventilator and handbagging them and kind of recruiting their lungs can help, but help get them out of that and get their sats up. But sometimes you're going back and forth. So there's things you can do. They're sedated because they're intubated. You can paralyze their body. Paralyzing them gets them to stop moving. So maybe they have better synchrony with the vent. And if someone's moving around, their muscles and all that is consuming a bunch of oxygen. Well, if you paralyze them, you take that out of the equation. So they start consuming less oxygen, and maybe their demand goes down. And that helps their oxygen saturation. That often helps. Maybe they're septic and they have a fever, so they need antibiotics to stop that septic inflammatory response, which is also consuming oxygen. You can also start a pulmonary vasodilator, like inhaled nitric oxide, alprostadil, epoprostenol. These dilate the pulmonary vasculature to allow better capillary flow around the lungs to maybe increase your oxygenation. It doesn't always work. Sometimes you do get a little bit more if you use that. Sometimes you don't. I will use it. If someone is really going down the drain, they're intubated, and they're on 100% everything, I'll be like, bring it in. Let's start it. We got to get them out of this. They're paralyzed. Let's start it. And then there's other therapies we talked about. Now we're getting into this, like ARDS, hypoxemia, which is a whole other topic, right? I love ARDS. I could talk about ARDS for hours. So proning a patient, right? I'm sure you've heard of that if you're non-medical. Proning can definitely help oxygenation. I mean, it definitely does. For several reasons. It changes the ventilation perfusion mismatching. So that the posterior lung fields, when you put someone on their belly, it can change that dynamic and it can help their oxygenation. It probably also helps mobilize secretions out of the posterior lung fields. And it helps, aeration in different lung fields that maybe weren't getting it before and now they are. That's something called the baby lung theory. Anyway, I'm not going to get into that. Okay, so you do all these things and they're still super hypoxic. Now what? ECMO, right? ECMO, VV ECMO, which is also what I do in my practice, which is a topic for another time. I've talked about ECMO on this podcast before. You can go check out that episode as a nice continuation of this. Anyway, I think that's it. So today we talked about hypoxia, what it is, all the things that contribute to it. There's a much larger discussion as well. There's many things I didn't talk about, many other therapies I didn't talk about, and many ways to treat hypoxia. That's just kind of a general overview. It's a huge part of my job, right? Because I'm an anesthesiologist and an ICU doctor. I deal with hypoxia every single day that I'm at work. Every single day. So it's really the bread and butter of what I do. And I love it. It's great. I love it. All right, let's switch complete different gears here. I'm going to talk about a book which you may have heard of. It's fairly popular. It's called Listen Liberal, or Whatever Happened to the Party of the People by Thomas Frank. Thomas Frank, he's a great writer. He was a columnist of the Wall Street Journal, which I'm not a fan of that journal, or Rupert Murdoch for that matter. But don't let that judge him too much. He's a great writer. I've read a couple of his books, and this is one is worth bringing to your attention if you're not familiar with it. Okay, so Listen Liberal was when was it written? 2016. It's about 300 pages long. So it's a well-worn diatribe against the liberal establishment. I really agree with his views about what's happened to the Democratic Party that he talks about in this book. He uses like both a scalpel, very precise with his arguments, and a hacksaw, just really dismantling the myth of virtue from the Democratic Party and how it's actually moved away from being the party of the people to the slightly less right party of corporate interest, which it is the party of corporate interest, just along with the Republican Party, in my opinion. A profound observation for me was that the liberal class is the professional class. They go hand in hand. While that's quite obvious at face value, this statement actually explains a lot. The liberal professional class has morphed the Democratic Party into a bunch of technocratic wonks who just bask in their own meritocracy, right? They just think they have things figured out, and they think they've gotten there by their own merit. They went to school, they worked hard, et cetera, et cetera. One of the harsh natures of a meritocratic state is that there is no inter-class solidarity. Meritocracy can only exist in a state of inequality. If the liberal class is the meritocratic professional class, then those same people will perpetuate the economic machines that promote the differentiated classes. Very interesting observation. The liberal class believes that education is a panacea to all social disparities. Armed with that belief, they apply theory over protest, constantly seeking to confirm their own ideology. The liberal class is obsessed with pining for consensus, rather than disgust or protest against the many, terribly dysfunctional processes that we have. All of the hand-wringing and virtual signaling has led to a very unfavorable outcome, complete abandonment of the working class. Rather than actually, legislation that directly helps working class, and that includes non-white people as well as white people, the liberal class only perpetuates its own class by buttressing itself with Ivy League wonks who seek nonsense social engineering like innovation or creativity, buzzwords, without affecting any real change. The liberal class flatters privilege rather than condemning it. The virtue quest is a distraction from neoliberal deregulation, which the Democratic and liberal class is very responsible for. in conjunction with conservatives. Frank offers a really scathing, if not kind of retrospectively obvious critique of Bill Clinton. Clinton ensured vast market deregulation. He, creating NAFTA, which, has been completely disastrous for our labor force, in my opinion. Clinton did racist crime bills that 100-to-1 crack to cocaine measures. He repealed Glass-Steagall, which was in place to prevent banks from gambling with the money that you deposit on speculative markets, which they have done since then, which was likely largely responsible for the 2008 financial crisis. And by the way, if Bill Clinton hadn't been embroiled in a sexual scandal, he very well may have privatized Social Security with his pal, Newt Gingrich. So, enter Obama and his claims of hope and change, who did little to change anything, with the opportunity to do so. Frank questions Obama's Wall Street bailouts, which could have been an opportunity to overhaul the entire financial system. While Obama did indeed institute the American Health Care Act, which has been good for some Americans, it is an overwrought and bloated law which seeks to keep insurance companies very much at the head of the table, and it was a gift to health insurance companies. Hillary Clinton claimed to oppose NAFTA and the TPP, the Trans-Pacific Partnership, while running in 2008 and 2016, yet was heavily involved in both of those trade deals. Hillary Clinton was a board of directors of Walmart in the 1980s. I mean, yikes. Anyway, and she also voted for the Iraq War. She's basically a neoconservative, on par with McCain and Romney. She really is. Hillary Clinton is a neoconservative, and from where I'm standing, there's nothing different from her from someone like Bush or Cheney, to be honest. Anyway, I'm willing to be challenged on that, by the way. Anyway, I could go on, but the point is clear: the Democratic Party is Republican light. It is a party that supports privatization, deregulation, social welfare austerity, racist crime bills, government surveillance, corporate monopolization, and neo-imperialism, all while serving up the politics of inclusion to virtue signal as a grand distraction. Is it any wonder there is class resentment for Democratic leaders of the Democratic Party? Is there any surprise that voters could be manipulated by a Wall Street demagogue claiming to dismantle the disastrous Democratic policies of the last 30 years? The illusion is that we believe there's a difference between the two corporate plutocratic parties. Now, I do believe there is more of a difference now in the rise of Trumpism. There is a difference, right? The GOP has become a political insurgency. They're not a political party. They've been hijacked by a political insurgency. So there is a big difference between them now. But I would say since the 1980s, they're up until recently, 2015, maybe up until the Tea Party, not a lot of big difference between the two parties. It goes without saying that Republican policymaking has been even worse for the average American for the very reasons I've just outlined for the Democratic establishment. They are two sides of the very same coin. The propaganda has devolved so much since the rise of Trumpism that it's got Americans to change our fear ideology from forward terrorism to domestic culture wars, right? People are afraid of their neighbor more than they are of foreign terrorism now, which is a really bad and alarming state for our society to be in. We fear and revile our ideologically opposite neighbor more than anything else now. If you believe that one party has inherently more virtue than the other, it's probably a sure bet you've been manipulated by propaganda. Now, that's just my opinion. Again, I'm willing to be challenged on that, and I want to be very clear. I do not believe the Republican Party and the Democratic Party are symmetrical. They're very clearly not. The Democratic Party is a fractured coalition of many, many interests that does not function well together, and whose politicians work for the corporate class. The Republican Party is a monolith political insurgency that has turned over to neo-fascist politics now. So these are very different. Anyway, we need a change. We need a new party. We need someone normal who actually cares about the average American. While I'm certainly glad that the blatantly corrupt Trump is gone, I have absolutely no faith that Biden will do anything to change anything. And he really, he's signed some executive orders, anti-monopoly executive orders. He's done some things. But I think he represents the exact same people that Hillary Clinton, Obama, Clinton, Bush all represent. So anyway, on to the next economic disaster, which is an inevitability. So anyway, that's that book is called Listen Liberal, or Whatever Happened to the Party of the People by Thomas Frank. I recommend it, particularly if you're liberal. if you're liberal and you're kind of like taking issue with things I'm saying, and I'm left leaning, right? Obviously, I'm like a liberal person, but if you're taking issue with the things I just said, read this book. I think it'll do you some good. Anyway, I think I'll wrap it up. I don't have time for questions, but anyway, let me know how you're liking this thing that I'm doing here. My email address is icudoctorecmo, ECMO, icudoctorecmo @gmail.com. I'm on TikTok. My handle is icudoctor. And on Instagram, it's icudoctor TikTok. So let me know, leave a review, and share with your friends. Thank you.